I feel very strongly that people need health care, and that affordable health care really is health care without any cost sharing, without any copays, because what I saw in practice was we operated on a sliding scale, and we were set up for people who were low income and including people who were uninsured. But every single day I saw people who didn't get health care they needed because they couldn't afford it.
Paging Dr. Cook. Paging Dr. Cook. Dr. Cook, you're wanted in the OR. Dr. Cook, you're wanted in the OR.
Welcome to the Prescription for Success podcast with your host, Dr. Randy Cook.
Hello, everyone, and welcome to the Prescription for Success podcast. I'm Dr. Randy Cook, and I'll be your host. Our podcast is a production of MD Coaches, providing leadership and executive coaching for physicians by physicians. To overcome burnout, transition your career, develop as a leader, or whatever your goal might be, visit MD Coaches on the web at mymdcoaches.com, because you're not in this alone. My guest today is a board-certified family physician who was a strong advocate for the underserved during her 34 years of active practice. Now that she's retired, Dr. Jessica Saxe continues to use her voice to speak up for the less fortunate. I'm pleased that she found the time to sit down with me and talk about how she does that. I am so happy today to be speaking with Dr. Jessica Schorr Saxe up in Charlotte, North Carolina. It's up in Charlotte from where I sit. Jessica, it's just a great honor to be able to talk to you today, and I'm looking forward to the conversation.
Great to be with you, Randy. I'm also looking forward to it.
Well, as we always do, let's see if we can get some of your origin story to begin with. I have a feeling that you didn't grow up in the Charlotte area. Where did you grow up?
No, I grew up in Northern Virginia near D.C.
I see. Was your family involved in government, or did you just happen to land there?
Oh, yeah. My father he did a number of different things, but he was in and out of the government.
Where then did the influence come from that interested you in going to medical school?
Well, the first time I was interested in being a doctor, I was about 6. And
that's an early start.
It was an early start. Well, weren't we all precocious? It was an early start, and I was very committed to it. And for several years, from like about 6 to 10, I read every children's doctor book in the library, and we had some kind of Red Cross book, and I practiced bandaging, and I told everybody I was going to be a doctor. And that was in the 1950s. And to my parents' great credit, they encouraged me. Nobody ever said to me, girls can't be doctors. Although that would have been the conventional wisdom at the time.
That is precisely what I was going to ask next. Did you ever feel any of that kind of pressure from anybody? But it sounds like the answer was no.
Not from my family at the time. But I did kind of drop the idea when I was about 10 or so. And then I became more kind of a, humanities, social science kind of person in middle school and high school, and wasn't really interested in science. And I think that probably some of that had to do with socialization, the feeling
Sure.
that wasn't really what girls did. And really, I thought I had left that far behind me.
Yeah.
Then when I went to college, I went to Oberlin College, and the first year I was there was the first year that Oberlin had a winter term in January where you could pick something else to do, that wasn't necessarily academic. Mm-hmm. And I had done all kinds of volunteer work, which is mainly social work kinds of things, but I had a friend there who had been a nurse's aide, and that sounded like kind of a cool thing to do. So I got trained to be a nurse's aide. I went to the hospital, the tiny little hospital in Oberlin, and asked them if they'd train me, and they did. And then I went and worked at Grady Memorial Hospital for a month, with that little tiny bit of training. And I was just doing it as something different, to do a different kind of volunteer work. But I found that I got just really interested in it. And so I went back to Oberlin and said, what do I have to do to be a pre-med?
That's a great story. And one thing that I would like to ask you, for purely personal reasons, did you learn anything during those nurse's aide years that you found to be valuable once you became a physician?
That is a great question. I think I learned some things about taking care of patients. You're really close to them as an aide. Mm-hmm. You spend more time with them. I think it was a good experience. And actually, I think it's really great now that as far as I can tell, most nursing programs have nurses start out and get their CNAs and work directly with patients.
Yeah. Indeed. Yeah, I had an experience as an orderly prior to getting into medical school, and I think it's the most valuable educational experience in the entirety of my medical education. But that's another story. We're here to talk about you. So what happened then when you got back to Oberlin and asked what you should do to prepare for medical school? What did they say?
So I remember going to the pre-med advisor, who kind of said I couldn't do anything right away. I already had my second semester courses, and what I needed to do was take science courses that were year-long courses. Mm-hmm. So I couldn't do anything until my sophomore year. So my sophomore year, I jumped right in, and I took calculus and Chem 101. I had not had any math or science since my junior year in high school, since I wasn't a science person. Well, yes, wow would be exactly the right reaction, because it just about killed me.
Did you at some point think maybe you'd made a mistake once you got into that?
Well, yes, very shortly. I mean, calculus actually was okay. Chem 101 was, I think, the hardest course I ever took in my life, but I didn't know that at the time. I just knew it was the hardest course I'd taken that far. And our chemistry course had physics in it, and I hadn't taken any physics. And as far as I could tell, I was in a classroom in which everyone else was a freshman pre-med who had gone to Bronx High School of Science. And I just felt so far behind. And then in the middle of the year, I kind of said to myself, well, am I going to stick with this, or am I going to take my junior year abroad, which I know will be fun, or am I going to do this, which I don't know? I didn't know whether it was really going to go anywhere. And so that was not a very hard decision. And I decided to spend my junior year abroad, which, now I see the medical students do it all.
You bet.
They're pre-meds, they go abroad, they have these experiences, they do all kinds of things. But back then, if you were pre-med, you kind of guess you can probably identify with this.
Absolutely.
You tread the path that's set. Yeah. And you weren't supposed to do anything off the beaten track. The interesting decision I did make was to finish those courses, though. And so I finished my year-long courses, and I went away for a year. Then I came back, and I wasn't sure what I was going to do. And kind of at the end of my senior year, that I started thinking about medicine again. My father, who was very wise, but usually tried not to intervene, had this very gentle conversation with me. And he said, I think this is what you really want to do. And so then I set out to pursue medicine for the last and serious time.
You have such a broad-based background that I'm really impressed with, and I'm wondering if you could talk a little bit about your experience at the Jacob Hyatt Institute in Jerusalem.
Oh, well, that was really great. That was the beginning of my year abroad. It was a program that was through Brandeis University. That was the Hyatt Institute, and we got a really broad education about the history and culture of Israel. So it really was on par with American universities, and the quality was good. And I learned a lot of things there that I remember to this day. And I also learned, I was there for 6 months, and then I knew that that wasn't enough. I just felt like I wanted to stay for longer, and I wanted an experience where I wasn't just surrounded by other American university students. And so I arranged to do a volunteer job in Jerusalem for basically another semester. I worked in it was called a social club for chronic mental patients, where we taught them behavioral skills.
Wow. And that must have been a powerful experience, to say the least, for someone of such tender years.
Oh, it was a very powerful experience. It was great. Yeah. I mean, it was wonderful. I mean, it was another experience where I was a little out of the regular culture. I was younger than anybody else who worked there, but I was treated like staff. And it was just a really great experience.
I'm going to have to say, I think you had the enormous good fortune to have done it right. You and I actually were training in medicine, doing our beginning training in medicine almost simultaneously. And I can guarantee you I had nothing like the diversity of the experience that you did. So congratulations to you. It sounds like you sort of stumbled into it a little bit, but I bet it made you a much better physician. But let's move the story along a little bit. So you got yourself into medical school at Tufts. And one thing I would like to know is, were there multiple applications, and did you get accepted everywhere, or was it hard to get in? What's the story there?
Oh, no, I didn't get in everywhere by any means. I think I applied to 12 schools. I think I got into 3 or 4, but I know my family were New York residents at that time, and I got into Buffalo. I also got into GW, which of course was in Washington, which is where I had lived, and I also got into Tufts.
And so how'd you pick Tufts?
An interesting reason I picked Tufts. I was interested in community medicine, and I knew something about the community medicine that had been there. Jack Geiger had been on the faculty there, and he had been instrumental in starting, I believe, the first neighborhood health center in the country at Columbia Point. I think that's right, in Boston. And he had also been involved in a project in Mississippi. And so I felt like that was a good place that had community medicine.
But the thing that impresses me about this the most is how deliberate you are in making these choices. And the entire medical school experience, when you talked about finding the science intimidating when you were an undergrad, but did that change any when you got into medical school?
Oh, I still found it very intimidating. Medical school was very hard for me. It was just it was one of the hardest periods of my life.
Hi, I'm Rhonda Crow, founder and CEO for MD Coaches. Here on RX for Success, we interview a lot of great medical professionals on how they grew their careers, how they overcame challenges, and how they handle day-to-day work. I really hope you're getting a lot of great information. But if you're looking for an answer to a specific problem, management or administration challenge, or if you're feeling just a bit burnt out, like maybe you chose the wrong career, well, then there's a faster way to get the help you need. No, it's not counseling, it's coaching. RX for Success is produced by MD Coaches, a team of physicians who have been where you are. I know you're used to going it alone, but you don't have to. Get the support you need today. Visit us at mymdcoaches.com to schedule your complimentary consultation. Again, that's mymdcoaches.com, because you're not in this alone.
We'll get back to our interview in just a moment, but right now I want to tell you a little bit about Physician Outlook. If you haven't discovered this remarkable magazine, please do so very soon. It was created by physicians, for physicians, to showcase the intersection between clinical and non-clinical interests. Whether it's writing, painting, cooking, politics, and dozens of other topics, Physician Outlook gives a physician perspective. It's available online and in print. It's really unique among physician lifestyle magazines. And like the Prescription for Success podcast, Physician Outlook amplifies the voice of any physician who has something to say. It also engages patients who still believe in physician-led, team-based care. And Prescription for Success listeners can get 3 months free when you enter our promo code RX4Success and select the monthly option at checkout. That's a really great deal on this stunning publication. And now let's get back to today's interview. Was it the nature of the subject matter or was it the volume?
It was both. It was how grueling it was. And also that it was, when you and I, where did you go to medical school?
University of Alabama School of Medicine in Birmingham.
Okay. I imagine if you went about the same time I did, that it was basically Monday to Friday all day long. We had half the day off for electives. Actually, there were 2 reasons I didn't want to go to GW. And one was that it was the most expensive medical school in the country, and possibly still is. I don't know. And the other was that they had an anatomy lab on Saturday morning.
Oh, my goodness.
Right, exactly. And I was like, really, I think Monday through Friday is enough. And then, and then you start, you're in class all day long. And then after that, you study.
Wow.
I found that grueling, and I had been interested in medicine because I liked working with people. And, the first 2 years of medical school, they didn't let us near any people.
And were there any moments during those first couple of years where you thought, maybe I made a mistake, or did you just feel like it was part of the test?
I think I felt like it was part of the test. I don't remember moment to moment, and there may have been moments that are thankfully erased with time. I don't remember seriously thinking of quitting. What I remember saying to myself really all through medical school, even the hospital part, which was better in some ways, was that I kept saying, this is medical school. This is not medical practice. Right. Medical practice will be different.
Yeah. In many ways, it sounds like a fairly typical medical school experience. At some point, you made the decision that your career choice was going to be family medicine. And I'm interested to know, did you know that going into medical school, or did it happen somewhere along the way?
I knew that going into medical school. That was the only way you came out of Tufts as a family doctor at the time.
Well, it was very new at the time. My recollection is there was not even board certification available. So you were a trailblazer, just like everybody else in family medicine.
Yeah. Well, that's interesting. I mean, there was board certification by the time I finished my residency in 1980.
Right.
But it was fairly new. That was one factor. And the other factor was Boston. I was in Boston, which considered itself, the medical mecca of the world, and that if it wasn't in Boston, there couldn't be any value to it.
Yeah.
So I came across that quite a bit.
So I think that leads me into the next question, and that is the decision of where you were going to do your postgraduate training, your residency, and you picked North Carolina. So tell us the story of how that unfolded.
Well, I had this epiphany when I was deciding that I'm going to a residency. I realized that I didn't like cold weather, although I had lived in cold weather my entire life.
That's a good reason.
And so that was one thing. And I also didn't like the chill about family medicine. So I wanted to go somewhere that was warmer, both in temperature and toward my chosen path.
When you went for that interview, how were you struck by what you saw in North Carolina?
I liked living in Durham. Another early memory just about being in the South, not about the residency, was that I went to the mall. I can't imagine how I ever had time to go to the mall, but I must have had half a day off or something. Oh, it was probably during our orientation. And I was with a friend, and somebody just took all the time in the world answering our questions and waiting on us. And as opposed to, like shopping in New York or Boston, where it would have been bam, bam. And I was like, gee, this is a different way of life. I think I could get used to this.
So you liked the Southern vibe. That's good news.
Yeah, I did. I did. I liked it, and I liked my residency a lot. And it was the first place that I think that I really felt at home in medicine.
Well, that's good to hear, and I also think that it's very interesting. I don't think I have to explain it to you, of course, but Duke University considers itself to be a significant epicenter of higher learning in medicine. But it sounds like their attitude toward family practice was noticeably different from what you had experienced in Boston. Is that fair to say?
That's a very interesting question, Randy. The attitude of the university and the medical school itself was not that warm toward family medicine. They had a department of family medicine, I think, because of pressure or money or both from the state legislature, as I recall. And the medical school itself was not that warm to us. We practiced at a different hospital, and we had a clinic that was separate from Duke, and we only did a couple of rotations that were actually in Duke Hospital.
That's interesting. Do you think that's different now? Do you think the bigger universities are better equipped at recognizing that there is a big need for family medicine in the big cities or not?
My impression is that there is a big change. I think family medicine is more accepted at Duke. Also, Tufts now has a department of family medicine, has for several years. In fact, one of my co-residents was the chair of family medicine there for several years. And when I heard that they were doing that, I was like, oh, this is really a sign that times have changed.
Yeah. Well, let's talk about what happened next. When you finished your residency, did you have any problem deciding where you were going to locate after that?
Yeah, I had some problem. I wanted to go somewhere. I thought I wanted to go somewhere that I had lived before, but that was conducive to family medicine. And you remember, I don't like cold weather. So that kind of narrowed it down. And actually, I had, like you said, I strategized, and I had a whole strategy to go to Washington, D.C., where I'd grown up. And I had some interviews, and I was interested in working in a health center. And I had some interviews at Washington that were just terrible. The centers that I interviewed with were just clearly very disorganized. And so that didn't work. So then I went back and I thought, well, I've spent all this time, developing this career, and I ought to go someplace that's really a good fit. And then I just kind of looked again. And the way that I ended up here in Charlotte is that I read the New England Journal of Medicine, of course, because I'd gone to Tufts. And lo and behold, there was an ad for a neighborhood health center in Charlotte in the New England Journal of Medicine.
Wow. How about that?
Yeah. And so I came down here and interviewed, and I got the job. I think I was the only applicant. and it was a low budget kind of thing. And the I don't know why the medical director put it in the New England Journal, except that he'd done his family medicine residency at Worcester, Massachusetts. So I don't know, maybe that. But anyway, that was where I saw it. And so I came down here for this job.
The process of making that connection, obviously, there was somebody in Charlotte who wanted to give you an interview and show you around. Can you tell me a little bit about that process? I mean, this is a little bit of a big deal. What was the interview process like when you got there? Did you think, oh man, this is really it? Where were you when you were in that phase?
Well, it's funny because now you're really asking a historical question about what an interview process was like. When I see how people interview now and how institutions handle interviews and everything, and when I think about how it was for me, it makes me laugh, really. It was very casual. I think I drove down one morning from Durham and went to the interview and spoke to the medical director, saw the health center. We went out to lunch, but there was nothing very formal about the interview at all. And they never, I don't even know if they paid my mileage. But there were no arrangements. They didn't put me up. Yeah. I didn't meet a whole lot of people, but I liked the setting. It was very small, and and I wasn't in any way sophisticated about asking any kind of questions about it. I don't think my residency really prepared me very well for that. And I knew there would be two of us, so I knew there'd be every other night call. That was just what you expected then.
Sure.
And I didn't ask a lot of other questions. I mean, I never asked questions about like 401ks or retirement until many years later, when things became more formal, those kinds of things came up.
You bet. But tell me a little bit more about the nature of the practice. Was this a fairly standard, here's a family doctor, come and see us, or was it more set up to handle the underserved population? I guess what I'm getting at is when you developed that interest in the needs of the underserved.
I had always been interested in serving the underserved. And I knew that was what I wanted to do. I didn't look only at places that were specifically for the underserved, just being where I felt like I could do the most good.
Mm-hmm.
And this health center that I went to work for was not a federally funded health center ever. It had come under the hospital, which was not a hospital system yet. It had been started privately by some churches, and then the year before I got there, it came under the hospital and was a part of the hospital. But it was the only off-campus outpatient setting in the system, and really they didn't know what to do with us.
When you say they didn't know what to do with you, who are the they? Are these just the bureaucrats that were tasked with recruiting physicians, or what?
Right. Well, the hospital administration.
I see. Yeah.
I mean, we were just kind of out there.
Sure.
There wasn't anything else like us in the system, and they had other priorities.
Yeah. So once again, you were blazing a trail.
I guess in some ways.
Well, tell us about those first few years.
So the health center was across the bridge from a housing project. That was how we described it, but it literally was across a little bridge you could walk across from. I think it was probably the biggest housing project in Charlotte at the time and no longer exists. So we got patients from there, and we got patients from another housing project that were nearby, as well as patients could come from anywhere. Most of them were low income. Many of them were Medicare and Medicaid. Many of them were uninsured. We had a sliding scale that was probably pretty minimal at the time. I mean, there were probably people who paid $0 or $1
mm-hmm.
to come see us. And it was pretty much us. We didn't have a lot of other support in the hospital system. Like, we didn't have a lot of specialists that we could refer patients to.
Mm-hmm.
We had some, and some of them were on the basis of like relationships that we developed with other doctors who were willing to do a little of what they considered charity work.
Mm-hmm.
And I believe there were some clinics at the hospital because the hospital's it was Charlotte Memorial Hospital then, and it was a teaching center. We probably had access to some clinics, but we saw everything, and we saw really sick people.
I bet you did.
And yeah, I mean, another thing that used to make me laugh is that at Tufts, people used to say, well, what do you want to go into family medicine for? All you'll ever see are runny noses. And, and we saw all these people who were really sick, who hadn't had medical care, who walked in. And I really liked it.
Did it take you by surprise at all about how neglected how immense the neglected population actually is?
Yes and no. I mean, I saw a lot of things that I shouldn't have seen. I don't know whether I was surprised. I kept on seeing more things. I would think I'd seen everything, and then I would see something else.
Mm-hmm.
I mean, I remember a woman who walked in with a huge tumor in her face.
Mm-hmm.
And it had just gone, she just hadn't sought medical care. And we would see people like that, people with advanced illnesses, because they hadn't felt like that they had a source of care or anywhere that they could go. A lot of that was very sad.
Yeah.
but we also felt like it was good that we were there taking care of them.
So tell us how things progressed. You eventually became the medical director of prevention and community wellness for Carolina's healthcare system. How did you make that transition?
Well, I had always been interested in prevention, and that was something in my first couple of decades of practice that became a big interest to me. I mean, the way I talk about it is that I got there and I thought that I was going to solve all kinds of problems in the community, that I was going to stamp out teen pregnancy and poverty and alcoholism and who knows what else. And I worked hard and my colleagues worked hard. And after I'd been there, 20 years or so, one of the things that I realized was that the health of the community around me was worse than it had been when I got there.
Really? No progress at all?
Well, progress in some things, but there are certain things, like there was a lot of substance abuse when I got there that I think was mostly alcohol. Mm-hmm. I got there in 1980. That was right before AIDS took off. Mm-hmm. It was, before we had an AIDS test. So when AIDS came upon us, we were hugely impacted. We had a lot of AIDS patients. And there were a lot of drugs. And then the other really big thing that happened was the burgeoning, so to speak, of obesity. That was not nearly as bad in 1980 as it was 15 or 20 or 25 years later. And with that came things like more people with type 2 diabetes, more hypertension, more heart disease. And I remember seeing a young woman who was about 20, whose mother was also my patient. Mother, and maybe her grandmother was my patient too. But anyway, she's about 20 years old and she weighed about 220 pounds or something. And I thought to myself, I think her grandmother maybe had heart disease, but I thought she is at risk for having even earlier hypertension and heart disease than the generations before her. And this is just not moving in the right direction here.
Yeah.
So I got very interested in prevention.
Well, it's pretty easy to see where the inspiration came from, and particularly anyone who has lived in the southeastern United States, like you and I have perhaps seen a different view of it. But it sounds like it was a very rewarding practice for you. And it is also very clear that even though you retired from active practice, I think like back in 2015, is that right? Or was it?
That's right.
Yeah.
That's right.
You have still remained very active as an advocate for the underserved. And I want you to tell us a little bit about Healthcare Justice North Carolina, or Healthcare Justice NC, I guess is the proper trademark. But what's the story there?
I had always been in favor of universal health care and of a single-payer healthcare system. And I think that I've been a member of Physicians for National Health program almost since the beginning, which was in the 1980s. But I had never been active. And what actually happened is that in 2009, when there was discussion of health reform, there was a lot of people talking about how doctors were opposed to health reform. And I had not been politically active, but I said to myself, it's time to take a stand. At the time, in the summer of 2009, it looked like they might sink the whole thing. And I thought, well, if it doesn't happen, at least I will have said something about it. So I got together a group of doctors and who were in favor of health reform, and we basically took a position in favor of it, and we talked to people, talked to legislators, wrote letters, and so on. We were just kind of an ad hoc organization at the time. But after it passed in March of 2010, we decided to stay together and to continue to try to work on health reform. And after about another year, we got a presentation from someone who was in Healthcare for All North Carolina, which is a chapter of Physicians for National Health program, came and talked to us about single-payer healthcare. And at the time, we voted that we also would support single-payer healthcare, which basically is the same as Medicare for All. And a couple of years after that, we actually kind of formally formed our own organization, Healthcare Justice North Carolina, in 2013, and have been supporting it ever since, which we do in the community by wherever we can. We do it by giving talks and going to festivals and parades and talking to people there. Of course, those are all the things we did before the pandemic. And also talking to our legislators and lobbying them and so on. I feel very strongly that people need health care, and that affordable health care really is health care without any cost sharing, without any copays, because what I saw in practice was we operated on a sliding scale, and we were set up for people who were low income and including people who were uninsured. But every single day I saw people who didn't get health care they needed because they couldn't afford it. Even if their copay was $10 or $5, sometimes they didn't have that money in their pocket for their copay, or they didn't have the copays for their drugs. And I really saw people suffer from that. So I have been working on that and promoting it ever since.
Are you seeing any movement of the needle at all? I don't think I have to point out to you that it's hard to find a physician who doesn't break out in hives when they hear single-payer health care. So have you seen some places where you're fairly confident that you're making a difference?
No. Actually, polls show generally that over 50% of physicians are in favor.
Really?
Yeah, I kid you not. And they have for several years now. It divides by specialty. And like you happen to be a surgeon, right?
Correct. Used to be.
So, right. So primary care, not surprisingly, primary care and psychiatry are generally more in favor. And the physicians that are opposed, it partly, I'm trying to think of a tactful way to say this. It partly divides along. Then I won't be. It largely divides along the lines of remuneration.
Yeah, that makes sense.
So the high-paying subspecialty physicians are the ones who are most adamantly opposed, and primary care doctors, psychiatrists tend to be more in favor. But polls show over 50% in favor. So that's one thing. And something I could tell you, you asked about signs of moving the needle. There's several things. One is that 10 years ago, if I would tell people that I was in favor of a single-payer healthcare system, people's eyes would roll and they would say, is that still around anymore? Isn't that dead? And or they would say, oh, no doctors are in favor of that. But now when you bring up Medicare for all, which again is basically the same thing, when I bring that up with people take it as a serious topic. And so then I take that as progress.
That is encouraging that you can at least have a conversation about it. And my feeling, you just heard me say that most of the doctors I hear talk about it are just vehemently opposed. And the truth is that, I've never polled a representative group. It's hard to know, frankly, for me, when you look at the throwaway journals and the way people respond. The people that respond are usually the ones that are opposed. And perhaps there's a huge number of people who are simply not. But I'm very encouraged that you think you're seeing some progress. That's good news. Let me throw a couple of examples out. The sorts of things that land in your email, like MedPage Today and Kevin Poe, MD, and those kinds of things, those are actually, they carry some pretty good information, but yet the commentary that you see to the articles that become published can be sort of angry. So that's what I'm basing my impression on, and I'm glad to be proven wrong, by the way.
I don't know whether proven, but maybe looking at some polls that are a little more randomized than who has time to vent their spleen, would be one way to go. But and actually, one of the things that bothers me a lot about the commentary is that it's so full of flaws. For instance, for instance, calling Medicare for All socialized medicine, which it absolutely is not. It's not socialized medicine. That's one thing that gets thrown at it. Another thing that people talk about is, well, if we have Medicare for All, we'll have wait times. And, people go on and on and on about that. Now, first of all, it's not necessarily true. There are some single payer countries that actually don't have wait times. Some do, and it's well publicized, and they're trying to work on it in some of those countries. But another, for instance, thing to throw out about that is, so my patients who were unfunded never got on wait lists. If they needed elective surgery, like if they needed orthopedic surgery, if they needed a knee replacement, there was no option for them. So their wait times were infinite. So, if we were calculating wait times, where would that put us? But it's not just misinformation, it's disinformation out there. And the people who object to it typically say the same things over and over again. The same kinds of things that you hear everywhere. Another thing I just wanted to say about evidence of progress is that there's a bill in Congress, a Medicare for All bill. There's been a bill since about 2004. There was a new one last year, but there were never any more than like 80 some co-sponsors in the past. And this bill that Pramila Jayapal entered has, I believe, 119 co-sponsors. So even while you're thinking there isn't progress, there's progress being made.
Well, it obviously requires a bit of patience to deal with that, and that's something that surgeons are not famous for. So we're very fortunate that we have family practitioners such as yourself who can keep their shoulder to the wheel and maybe bring about some change. Well, Jessica, I've really enjoyed hearing your story, and particularly the encouraging news about how we can better pay for health care in our tortured nation. But what I'd like to do at this point is get out of your way and give you a chance to do what we're here for, and that's hear your prescriptions. So I'm going to close my mic, and Dr. Jessica Schorr Saxe is going to give us her prescriptions for success.
Have a vision of what you think medicine should be and what your place is in it. As you do, remember that you walk in the footsteps of giants: Hippocrates, Osler, Rebecca Crumpler, Arthur Relman, and many others. And by the way, if you don't recognize Rebecca Crumpler, recommend you look her up. She was the first Black woman physician and as brave, dedicated, and innovative as the people you've heard of. It may sound grandiose to think of giants when you might be feeling beaten down, but that is our tradition. Almost all of us took an oath to put patients first, to practice ethically, to respect life, and to treat patients without discriminating. As you follow your vision, make the best choices you can about where you can realize it. If you find yourself in a situation where others are making decisions, stay aware when those aren't consistent with your values. For instance, many decisions in medicine are made on the basis of business and are not in the best interests of patients. Oppose those when you can, but even when you're not successful, don't absorb them. I had a mantra when these things happened in which I said to myself, I am here for my patients. I'm not working for the administration. I'm working for my patients. If you need to and there's an opportunity, find a different job. But even if you're unable to, you may still be able to express your principles in a different way. One of the things that was very clear to me in practice was that people need health care. They need health care whether or not they can pay for it. And generally need it even more if they can. I couldn't always make that happen in practice, but remembering that is why I do what I do now in retirement, which is to work toward universal health care in the form of Medicare for All. Second, despite medical advances, despite technology, it's still all about the doctor-patient relationship. Do everything you can to nurture and protect it. Over the years, there's been more attention paid to the lifestyle of doctors. Call groups have gotten bigger. Offices have designated people to see sick patients so that doctors may be unlikely to see their own patients when they're sick. Setting those kinds of limits is important. But some of the most important and satisfying things you will do are those that are beyond your job description, maybe that you've been told not to do, like seeing or calling your own patients when you're not the one on call. And I want to share a couple of memories. One Sunday when I wasn't on call in the early 90s, one of my partners called just to let me know that a patient to whom I was close, who had AIDS, had been admitted. I went in to see her, and I will never forget her lying on a gurney, bald and frail, looking up to see me and saying, "Dr. Saxe, you came in on a Sunday?" A while after I stopped doing hospital medicine, I discovered a new form of communication. It was called the telephone, and I would call my hospitalized patients to check on them. Years later, when I talked to one of my patients about my upcoming retirement, the first thing she said was, "When you called me in the hospital, it made my day." Institutions often treat doctors as if we're interchangeable, but trust and our relationship with our patients is foundational. Protect it. Third, medicine and medical care are powerful, but we need to have humility and realize how many other factors are important to the health of our patients, sometimes more so than the medical care itself. These are now referred to as the social determinants of health. When I was in practice, I was aware of some of these influences, that poverty and lack of education compromised the health of many of my patients, that discrimination and racism affected the health of my African American patients, though I didn't realize how pervasive it was. I wish I had realized how profoundly the social determinants affect health. I encourage you to address these with your patients and also to find a way of doing so with your community, including with public officials. We physicians have stories to tell about the things we see, about the ways our patients suffer, and legislators often respond to our stories. And this all leads me back to the first piece of advice. Find your own North Star, let it guide you, and enjoy yourself along the way. And those are my prescriptions for success.
Well, Jessica, you have enriched our lives with a good bit of wisdom there, and I am really grateful that you were willing to join us today. Before we go, I want to give you an opportunity to tell our audience where they can find you and any organizations or websites that you might be passionate about. So please go ahead.
Well, I encourage you to see what my organization, Healthcare Justice North Carolina, is doing. The website is healthcarejusticenc, all one word, .org. And we also have a Facebook page, which is Healthcare Justice-NC. Our parent organization is Physicians for a National Health Program, which has been supporting single-payer healthcare for over 30 years. There's a wealth of information there. That website is pnhp.org, and I would encourage you to look at it and to join it as well. And if you would like to contact me, you can reach me at my email address, which is jessica.schorr, SCHORR, .saxe, SAXE, @gmail.com.
Jessica, it has been a real honor and a pleasure to have you here. Thank you so much, Dr. Jessica Schorr Saxe. We have really had a great time together, at least I have, and I hope you have, and I know our audience is going to enjoy our conversation. Thanks.
And thank you so much. I've also enjoyed it very much.
Thank you so much for joining us today. If you'd like to learn more about today's guest, just head on over to our Patreon page where you can access exclusive content, including a rapid-fire Q&A session with our guests and more. Never want to miss a future episode? Visit our website at rxforsuccesspodcast.com to subscribe. You can even offer your very own personal prescription for success. As always, we appreciate a review and a 5-star rating, as well as suggestions for future show topics. And finally, special thanks to Ryan Jones, who created and performs our theme music. That's all we have for now, so be sure to fill your prescription for success with my next episode.